Hello and welcome to the second part of our Conversations Confronting COVID-19 series. Through the series, we will be featuring the work of Queen's students, researchers, and alumni leaders working on issues that matter to all of us as global citizens. My name is Karen Bertrand, and I am the Vice Principal Advancement at Queen's. I'm a proud Arts I-94 grad, and I will be your host for the next hour. This event will be a question and answer event, and so I do encourage you, if you have any questions throughout the next hour, please feel free to enter them by clicking on the Q&A function on your webinar control. I will caution you, we have several hundred people already online, and we have over 1,400 participants registered to participate in today's meeting. So we will do our best to get to as many of the questions as we possibly can. I should also caution you that this event is being recorded and it will be available on our website in the coming days should you like to view it again or share it with somebody who was unable to join us today. Today our topic is aging. We're going to explore how the COVID-19 pandemic has impacted the lives of our most vulnerable population, our seniors. And at this point, I would like to introduce our moderator for this event. Dr. Jane Philpott is an accomplished physician, educator, and global health champion. She is best known for having held several senior cabinet positions with the Canadian government. From 2015 to 2019, she served as Minister of Health, Minister of Indigenous Services, President of the Treasury Board, and Minister of Digital Government. Before becoming a politician, Dr. Philpott served as a family doctor for 30 years. She also served as Chief of Family Medicine at Markham Stouffville Hospital and as an Associate Professor in the Faculty of Medicine at the University of Toronto. Please welcome the new Dean of our Faculty of Health Sciences, Dr. Jane Philpott.
Good morning, and thank you very much, Karen, for that wonderful introduction. And what a pleasure it is to be here as part of the Conversations Confronting COVID series. I want to welcome everybody who has joined us today. What a fantastic response we have had from people here in the Queen's community, but I think probably all across the country and maybe even around the world. So it's great that everyone has joined in this very important conversation. I am delighted and honored to be the new Dean of the Faculty of Health Sciences here at Queen's University. And I've been in the job for about 3 weeks, and it has been an incredible whirlwind of activity already. I'm delighted today to be moderating this event that brings together, I think, some of what makes Queen's such an exceptional institution. We are bringing together the researchers and the expertise that bear on an issue that matters to everyone in Canada. We're going to be talking about the issues around aging, the elderly, and long-term care. And in the recent months, these issues have risen to the top of mind for all of us and for our public discourse. Of course, aging affects us all. Every one of us is aging every single day. But the issues and the challenges around aging have never been more relevant and have never been more in the forefront of our minds than through this crisis of the COVID-19 pandemic. I have certainly faced some of these experiences myself, and as was mentioned by Karen, I am a family doctor by background, and I did have an experience early in the pandemic where I had to deal with some of the issues around both aging and other intersectional vulnerabilities that are on our minds, and we'll touch upon some of those today. I spent several weeks working in an outbreak in a group home in the Greater Toronto area in the city of Markham, a place called Participation House that is a home for adults with severe disabilities, some of whom are young, but many of whom are old. And so you'll hear us touching today on not only the challenges of those who are aging in the context of a pandemic, but all of the other things that make them vulnerable, including the place in which they're aging. I'm happy today that I'm going to be joined by an incredible group of panelists who have been brought together through their connections with Queen's University, and they bring a diverse set of experiences. some on healthcare, some in the research area, and some who are policymakers and advisors. And so I think it's best that I invite each of these panelists to tell you a little bit about themselves before we dig into the content. And so I'm going to ask all of the panelists to put their videos on so we can see their shining faces, and ask them to say a few words about themselves and their work directly related to the topic of aging. So let's start with Laura Tamlin Watts. Laura, tell us about yourself.
Thanks so much, Jane, and thanks all of you for joining. So my name is Laura Tamlin Watts, and I'm the CEO of CanAge, which is Canada's National Seniors Advocacy Organization. I'm a proud politics grad in 1994, which is some years back. I have a background as a lawyer, and I ran the Canadian Centre for Elder Law, which is the Centre of Excellence on Law and Aging. I teach at the University of Toronto in law, policy, and aging as well. And CanAge has been very, very involved both in responding to the seniors issues that have been rising across this country, and also in the policy recommendations. So we're really pleased to share some of our key learnings today.
Thanks very much, Laura. And now, right straight from the bedside, providing clinical care, we're happy to have Kevin Wu with us. Kevin, can you introduce yourself?
Of course, thank you, Jane. My name is Kevin Wu. I'm associate professor at Queen's School of Nursing, and I'm also cross-appointed to the School of Rehabilitation Therapy as well. I teach in the nursing program and also in the Aging Health Masters and PhD program. I'm also part of the Canadian Frailty Network, some projects and research that I'll be sharing with you a little bit later on today. I'm so glad to be here to join the panel. Thank you.
Thanks very much, Kevin. Our next panelist that I would like to introduce to you is Catherine Donnelly. Catherine, tell us about yourself.
Hello to everybody. I'm an associate professor.
You're on mute, Catherine.
I think can everyone hear me now? Yeah.
Yes.
Hi, everyone. I'm an associate professor at the School of Rehab and also the director of Health Services and Policy Research Institute here at Queen's. My research looks at primary care teams and supporting older adults in the community. I'm also an occupational therapist at the Queen's Family Health team, and much of my clinical focus is working with older adults, and I'm also a proud Queen's grad.
That's fantastic, Catherine. I'm really proud of the diverse team that we have here today. And our final panelist I would like to introduce is John Puxty. John, tell us about yourself.
Thank you. I'm delighted to be here today. I'm what's termed an academic geriatrician. I've been working for the last 35 years plus here in Canada and the United Kingdom. I'm an associate professor within the Department of Medicine here at Queen's. My particular research interests have been in the area of frailty. So I'm particularly interested in frail, vulnerable older adults. I'm also involved in working what's termed age-friendly communities. How do we create communities that are going to empower older adults and hopefully avoid and mitigate effects of frailty? And also I run a regional memory disorder clinic here at Providence Care in Kingston.
Thanks very much, John. Well, I am quite delighted with the range of expertise that we have here on the panel, and I think we're going to have a great conversation. So I have a series of questions that I would like to start off with myself for the panelists. And following a few of those introductory questions, we are going to be opening the conversation for audience questions. So please go ahead and send in your questions anytime, and we'll try to get to as many of them as we possibly can. We are going to be talking, of course, the context of what has taken place over the last 6 months in the context of this pandemic, which has changed our lives so significantly. And I think we'll start with John, since we just had an introduction from him. And I think that I'd like to start with a bit of an overview, I guess, John, and your sense of, have we succeeded or have we failed in our duty to safeguard the most vulnerable members of society? And specifically, of course, today we're thinking about the elderly. How would you say we've done?
I probably would give us a sort of 7 out of 10 grade overall, and I'll explain that. First of all, I think it's important to appreciate that aging isn't automatically associated with vulnerability. So although looking at people over the age of 65, we find 10% are vulnerable, 90% are not. And even at the extremes of age, like 85 plus, it's only about 1 in 3 older adults are actually frail or vulnerable, as we term it. The real issue is not age, it's the presence of chronic multiple diseases, use of multiple medications, cognitive problems, and social vulnerability. Those individuals who live alone, who suffer poverty and isolation. So it's those individuals who we term frail, and they're the ones who've been particularly vulnerable within this pandemic situation. And a particular cluster of those individuals is long-term care. And there are a number of issues that should have made us aware that there were going to be concerns around the impact of pandemic in frail elderly in long-term care. Long-term care itself has a high cluster of increasingly frail, complex individuals. We haven't been creating long-term beds consistent with the demographic trends. So the reality is there's been a funnel effect. Only the most frail, the most complex have been going into long-term care, and we haven't been creating good alternatives in the community to long-term care for those individuals. So when people get into long-term care, they're very ill, they're very frail, they're very complex. Then our environment in long-term care hasn't been great in terms of design. At this point in time in Ontario, 1/3 of our facilities in long-term care are only meeting a standard of nearly 50 years ago, the 1972 standard, which allows for the facilities, amongst other things, to have individuals in 3 to 4 beds in one room, a room that's only about 305 square feet by the standard, and it's physically impossible to put more than 2 beds in one of those rooms and maintain social distancing. So we knew that upwards of 1/3 of our beds were going to be challenged by problems of social distancing. We also know that our staffing in long-term care falls behind many of our equivalent countries across Europe, Australia, and even the US. We underfund long-term care, and we have a disproportionate number of beds which are operated for profit. Not that for profit is a bad thing itself, but the reality is there's a much higher concentration of beds that we would consider substandard, i.e. category C and D, i.e. they've not been improved since 1972 standards. So we had a situation as we went into a pandemic where we had facilities where we couldn't ensure isolation, we had low staffing levels, and we had a very complex population. So we should have anticipated this problem earlier. There's been data recently released from CIHI, which did a snapshot of looking at long-term care across 17 countries, of which Canada was one. And other countries were countries in Western Europe, Australia, and USA, for example, for a comparison. And the reality is we didn't do very well. The overall incidence of COVID deaths across the population, we were in the lower half. But when we looked at the proportion of deaths in long-term care, it was actually accounted for 80% of all the deaths that occur from COVID, which put us in the dubious position of being the high scorer compared to averages for other countries like us of about 40%. So we've had a high mortality rate, and we haven't necessarily prepared ourselves for the situation. So that's why I give us a sort of 7 out of 10 mediocre grade.
Well, I think you might even be grading generously there, John. So But thank you for that perspective, and I'm really eager to dig in as we move along to think about your thoughts on the solutions to some of those real challenges that you've raised. But I want to bring in a few of our other panelists today, and I think you've touched on the real challenges in some of these facilities, the long-term care facilities, as well, of course, of other types of seniors' residences or retirement homes, and how people living in these homes have really been disproportionately affected by the measures that we've taken. As they've been disproportionately affected by COVID, but also by the interventions that have had to take place, like the quarantine measures, as well as, of course, the challenges around physical distancing. And I think we need to introduce right here this whole challenge around prohibiting access to family members, especially family caregivers, and the impact that has had on things like social isolation of some of these vulnerable adults that you're talking about. So I know that this is something that Kevin has given a lot of thought to. Kevin, what are your thoughts in terms of the challenges of some of the knock-on effects of the pandemic and how it has manifested, both in terms of physical impact, but also, of course, the mental wellness of aging populations?
Thank you, Jane. I think that's a huge concern from my perspective. And of course, we all have the experience of being isolated since the whole pandemic situation has begun. And I think the impact on the elderly is particularly more significant to them. The usual social support they receive in the past, they're no longer available to them. I'm talking about families that you have talked about just now, talking about other volunteers, the usual support services, friends, families, faith-based organizations, support. And as you're aware, that mental health concerns are very prevalent in the elderly population, especially in long-term care facilities. I think in some studies, they report as high as 1/3 individuals in long-term care environment exhibit some signs and symptoms of depression. So with social isolation, I think we see more and more problematic in terms of number of physiological and mental manifestation of the depression and mental health concerns. In particular, I'm talking about people not eating as well. People start to lose a lot of weight, and I mean, this has been reported in the news that people are basically they're not eating and they suffer from malnutrition. As a result of that, also part of the mental health issues may affect the sleeping pattern. People not sleeping as well, or they're spending a lot of time in bed sleeping. And the usual recreation activities, stimulation they receive on a regular basis, they're no longer available due to the isolation. And I think the major problem, and also I think John had touched on this issue with the staffing and the concerns, how to manage some of those responsive behavior. And responsive behavior, what I mean are those behaviors that often could be quite disturbing to some individuals who are not familiar with them, and it could be very difficult to manage. It may involve vocalization, it may involve people trying to find exit, it may involve people trying to hit people because they're just getting lack of that stimulation. So we see more and more of those behaviors because old individuals being in a lockdown situation, they're more frustrated. There's very little stimulation to them. They cannot see friends, they cannot see families. And not to mention about on a regular basis, what we see are basically people's eyes, because we're gowning up from head to toe. And imagine yourself, in the middle of night, someone come in, you can only see the eyes, and they're doing all kinds of things to you. And it's a very, very scary experience for those individuals. So I definitely, this is a major concern. And that's why I think in the future, in preparation for a pandemic situation like this, we need to think about how to engage our older individuals in long-term care using technologies, looking at mobile health technologies to help mitigate some of those isolation effects.
That's great, Kevin. And I think I'm very eager to think about what those could look like. Bringing in some of our other experts here today, I think it's fantastic how much long-term care has been on the minds of media and public conversations, and there's so much more attention to this now. But I've been surprised, I guess, in some ways that even though we've had that focus, there hasn't been as much conversation around what are the alternatives to the current approach to long-term care. And of course, John touched on this a little bit, but Catherine, I'm thrilled to have you here as somebody who has an expertise in primary care, which is where my interest lies. And I would love to get your thoughts on how we could be thinking differently around different models of care delivery and different models of housing options for the elderly. So what are you working on in that area, Catherine?
Yeah, thanks, Jane. So the focus in this pandemic, as you've alluded to, has really been on long-term and institutional care in general. And I'm going to shift the conversation a little bit, because if we think about where older adults live, 93% actually live in the community in non-institutional settings. And resoundingly, you will hear time and again, adults want to remain at home. And again, when we hear long-term care, and Kevin and John have alluded to this, it's associated with feelings of loss of identity, losing their family home, loneliness, being separated from families, and this idea of loss of control and that sense of agency. And when we think about alternatives, again, I'm going to be thinking more upstream in community. And these models have key elements when we think about how we can look at aging differently. And these models all are about how do we give older adults that sense of independence and autonomy, and actively engage them in decisions and their own advocacy, and also this idea of fostering social networks so they can support each other in the community. And I would say these models are really about community level interventions. And we traditionally and frequently turn to the healthcare system, institutions really, for our answers. But really we have to start thinking about how we can reframe aging differently, and thinking about building communities, whether that's at our neighborhood or building level, and really thinking differently. And so I'll just give you one example that I've been working on here locally. I've been working with my colleague Vince DePaul at the School of Rehab, and a program called Oasis Senior Supportive Living, which really embodies all these elements of alternative models looking at the community. And so Oasis is considered a naturally occurring retirement community, which is called a NORC, which is a really funny name and something I hadn't been familiar with either. And what it is, it's a geographical area, whether that's a neighborhood, apartment, with high percentage of older adults. And again, these are not intentional communities, and these are naturally developed. So a neighborhood that might age together, an apartment building that older adults gravitate to, maybe they're close to amenities. And so NORCs, they're excellent starting points for how we can think differently on alternative models, and intentionally look at social support networks in these communities, bringing programs, primary care to where older adults are living versus them having to go to institutions. And so we've been working with actually an incredible biostatistician, Paul, I've got to give him a shout out, Paul McEwen, at ICS here at Queen's, and we have access to population health and large data here. And he's actually helped us identify NORCs in Ontario. And we use census data, and we were able to map out all small geographical areas in Ontario, only 400 to 700 people in these little units. And it was remarkable. In 2006, 8% of these little regions were what we'd consider NORCs, high density. And by 2016, 20% of these areas in Ontario actually are considered NORCs. And so again, how do we think differently using what we already have, just sort of rethinking? And again, Oasis is just one example of how NORCs could be thinking about housing differently. And this is just a local Kingston example that we've actually been able to scale up across Ontario. And it was initially developed by older adults themselves in response to feelings of loneliness. And how could they come together in their own apartment? And they've got essentially 3 pillars, looking at communal physical activities, social activities, and communal dining that they actually have in their own apartment building. And they've actually worked with Homestead, a local building here in town, and who's donated space for a decade that they've run this program. So I can talk a bit more about it, but that's just one example of how we can think differently.
That's great, Catherine, and I love the creativity that you and your team are using to be able to look at options. And I know that Laura is a real expert in this as well, in terms of thinking of the big picture and the long-term strategy, and how are we actually going to learn lessons from the pandemic to influence that long-term strategy and drive that transformation. And I know, Laura, that you also look at things from a whole of Canada perspective, and how we can have a pan-Canadian approach to this kind of long-term transformation. I'd love to hear what you're working on.
So I think I'm a harder marker than John, just to say. I actually don't think that we've done a very good job with aging in Canada, because we've known what the challenges have been for many years. And John's point about the standards in long-term care being sort of circa 1972, we've known a really long time. And what we haven't done is actually take the steps forward and make the change. So they get a failing grade for me because we haven't actually done the things we need to do. And many of us were watching the COVID pandemic come Asia, Europe, and we started raising our hands up and yelling into the air saying it's coming. And we need to make sure that where we have more congregate care settings, we have more closed environments, that we prioritize those supports to those people. And we saw that in some places, we did a good job about that. And I think BC has done better. And I think in some other places, and I think Ontario and Quebec did a poorer job in that. And we saw the outcomes shift in that way. So there are some lessons to be learned. I know that we've got some questions about, how can we do it better now? And how can we do it really a lot better, knowing that the second wave is coming very, very shortly. So I'm going to kind of put my perspective on that. So at CanAge, we are about to release a national seniors platform, a full and comprehensive platform for recommendations. And I'm happy to share that with the Queen's community and everybody else when we release it on about the 7th of August. Many, many of those platforms are going to be looking at the system change that we need, Jane, just talking about that. And building on, Catherine's point and Kevin's point about, yes, it's true. When we're talking about long-term care, we're talking about a small fraction of older people. But that fraction, that proportion is going to be new numbers bigger, right? So the proportion may be small, but the many more people, because of our aging population, are significant. We also know that we need to make sure that we are aging in place in a more fulsome and robust way. Some of the questions that I saw come up are, how do we make sure that we turn things like home care into care at home? And that means integrated teams. It means that your doctor, that a nurse practitioner, that physiotherapy, occupational therapy, social work can be provided in integrated ways. And we know that some examples, like Nordic examples, have done an exceptionally good job at this, and as a result have seen very good planning in place for things like infection control. So I really think that when we need to think about long-term care, retirement care, we need to flip it over. It's care at home, what needs to get to where you are. But we know staffing changes, infrastructure changes, infection control changes. We know the solution, we just need to do them now.
Okay, well, that's fantastic, Laura. And I like the fact that you've already been peeking ahead at the questions and trying to answer them as you go, which is terrific. And folks, there are several questions that are coming in, so do keep your questions coming. And hopefully all of our panelists will do as Laura has done and have a little glance at them, so that as you're answering any question, feel free to touch on what you hear that our members of the participating audience are sending in. Just before we go to some of those audience questions, I wanted to make sure we touch on some sort of positive things. Sometimes it feels a bit doom and gloom, especially when we're giving failing grades out. But we all like to look at where are the silver linings. And this is a sensitive conversation because we're talking about a context where thousands of people have died, and we never should lose sight of that. But I think there are some silver linings in terms of our approach to aging. Anybody in the panel at all? I'll put this out to all of you. What do you think is good about what's happened over the last number of months? Do I have a taker on that?
I'll take it up.
Go ahead, Laura.
When we're talking about our issues, we often spend a little bit of time thinking about aging, but then we slip over to other things. In fact, we have a joke in the sector that says any conversation about old people, then we clock it to see how quickly we start talking about children and youth. And in some cases, we go into specific panels talking about aging, and it's under 3 minutes before we talk about children and youth. So there is little to celebrate in terms of the loss of life. What there has been is, I think, a new focus, a new understanding, and I think an empathetic connection that we've never had before. My first comment when they did a lockdown for people 70 years and over, was, well, this will be interesting for the boomer population that doesn't actually connect to the idea of aging and isn't self-identifying in any way of being vulnerable. And John, just picking up on the ideas of vulnerability, that social vulnerability that you shared, for the first time, many people who had never experienced what vulnerability felt like now understood, what do you mean I can't go to the grocery store? What do you mean I can't see my family? I'm vulnerable to this disease, and actually because of triaging, I might not get treatment. What does that mean for us? And so silver linings, well, it's a gentle thing to say, but I think until we as a society understand empathetically what it means to have that type of vulnerability and to see the impact and loss, we can't make that change. So I am optimistic that change can come and we have that new experience to draw upon.
That's great. Thank you for that perspective. John, you had some ideas about silver linings too. Why don't you jump in?
Yeah, so I feel a need to defend my low pass grade in my mind. I'm aware of some really incredible work that's been done in long-term care and other areas. And we mustn't lose sight of that work that's been done. So BC, for example, has some really good results in long-term care compared to other communities. So we shouldn't lump everyone together. And again, a lot of facilities I know here in Ontario have been very creative in responding and avoiding some of the issues around outbreaks and also mortality. So we can't paint the whole long-term care sector as a problem. We have an area which is this problem that we haven't maintained or insisted on these standards that we actually have in terms of our books. We haven't been actively monitoring and insisting on change, and we haven't been funding it. I think the silver lining is it's in front of everyone now. You know, the elephant in the room is very apparent. So I think it will be very difficult to ignore that going forward. And I wanted to touch on the issue of isolation and loneliness, because that's an example, again, of something that came about that's been really good. I have funding through the Ministry for Seniors and Accessibility to run a program to support age-friendly communities across Ontario. As part of that, we flagged this issue of isolation was emerging in communities, isolation in older adults. So we proactively organized a webinar to talk around this issue of isolation and vulnerability in older adults. And we had some 600 plus people registered. And after that session, there was so much interest, we've created a new community of interest around this issue of looking at strategies, best practices. And I've been able to get some funding to have a couple of master students doing some work around identifying those best practices and also doing a rapid literature review, which we plan to distribute through the community of interest. So there's all sorts of things, all sorts of wonderful models that are happening in Canada that we should be proud of.
Jane, I'm also going to pick up on a comment that was put into the chat about virtual health and telehealth, because I think that's really critical. So agree with both John and Laura that this has really shone a spotlight on the issues. And, you know, I'm thinking from a primary health perspective, we went virtual overnight. And, you know, some of the challenges with that are we recognize that some older adults didn't have access to technologies. And so I think we have work to do, but I also think we recognize in older adults, we've seen in our work with the OASIS program, are jumping on board with technology and learning technology and recognizing the value for the first time and how to not only connect with healthcare, but with family members.
Jane, if I can chime in, might as well, right?
Go right ahead.
In terms of my perspective. Right. So I think, and I'm not pushing as a silver lining, but it's more like a wake-up call for us. Maybe I'm still dwelling on some of the negative stuff from the pandemic situation. But definitely we need to think about how to reinvest into the workforce. We are dealing with a very disenfranchised workforce, people overworked, people experiencing burnout. especially long-term care again. There's very little investment, education, staff development in terms of improving people's knowledge. And when you think about how people deal with infection, how do they manage using the PPE, the personal protective equipment? There's very little education and support around it in the past. Perhaps it's an opportunity for us to really shifting our paradigm of thinking a little bit, refocusing not just a curative approach to the population, but also looking at the caring approach. Yes, I think as John mentioned, lots of older individuals are living with chronic conditions and chronic diseases. We need to think about how to care for them, not just curing those diseases.
Okay, that's great. So love the interaction between our great panelists here. I'm going to go, I know you've all been touching on some of the questions that have been popping up in our Q&A, but I'm going to go to some of those specifically now. And there's a real range of them, but I want to start with one that comes from Ashlyn, and she asks us about our thoughts in terms of Indigenous populations. And this is, I think, a particularly important one in terms of the impact of the pandemic on those populations. And how has your research, in particular, maybe some of you have been working with elders, looked at what the meaning of well-being is, community perspectives and ways of knowing and being. Anybody have any comments to say about what we can learn from Indigenous communities in terms of concepts of aging? Do I have a taker there?
I'm happy to take a little bit on that as well. At CanAge, we've been focused on partnering with Indigenous and First Nations communities, as well as Northern communities, and some of those pieces bend over together to understand both the experience of COVID-19, but also to look at it within the general context of what is aging in Indigenous communities look like. So the first thing to know is it looks a lot shorter. And that is really a failure of some of our, health and social care systems. So with an average age of death in the mid-60s for many Indigenous on-reserve communities, that's a stark comparison to what we would expect for 20 years of additional, more healthy aging. We also see a great intersection of comorbidities. Diabetes is one of the examples that we see, particularly in Indigenous communities. We are working in Nunavut as well to understand how to support aging in place. I sat next to a woman from Nunavut when I was giving some Senate submissions last year, and I was asking her about what is her experience living in a community that has no kind of formalized long-term care, or for that matter, assisted living, or really for that matter, any other kind of supportive care outside of what family and supports would look like. And she said something to me that was heartbreaking. She said, our elders were the very people that were taken away by residential schools. And now we've got them back into our community, and they're embedding our knowledge, and there are storytellers, and there are keepers of our culture. And because we have no integrated care, or very little in some other places like Yukon and Northwest Territories where some more is being built, they have to leave. And in particular, in Nunavut, they're mostly going to a retirement home Indigenous community wing, which is in Ottawa. And she says, we never see them again. So we have lost not only our families, we have not lost only our elders, but they have been re-institutionalized. And because many of them, of course, have memory and cognitive impairment issues, some of them are experiencing the trauma, re-traumatizing. We've seen this again in Jewish communities where we have Holocaust and so on. It's not a unique concern. So what we've been working in the North is to try to build capacity with a developing non-governmental sector and working with local communities. U of T is starting a certificate program to help family, friends, and essential caregivers. And I saw some questions in the chat about what is an essential caregiver. I'm happy to talk about that, to try to build up capacity so people can age in place, and understanding that when we take elders away from Indigenous communities, you don't just harm an individual, but you harm an entire community.
Well, thanks, Laura. That's a really great perspective. And I think, we'll talk with the folks that put this conversation together, but I think this might be something that we could have a further conversation about in terms of what it could look like going forward, because I do think there's a tremendous amount that can be learned from these from different ways of knowing, different ways of respecting Indigenous populations. So maybe the five of us might not be the best people. So let's make sure that that's something that we continue to look at. Okay, so I'm going to try to move along. There's such a diversity of questions here, so I'm trying to get to as many as we can. I want to. There's a few people that have been asking about policy advice, and you guys are the experts on these issues, and this is your chance to do a pitch on the jurisdictional issues associated with long-term care. And there are people that are asking about what the role of the federal government is in long-term care. Should these issues be brought in somehow under the Canada Health Act, for instance? That's something that I'm often asked. But I'd be interested in your perspectives as to what you think policymakers should do. John and others have referred to funding, which is a big part of it, but beyond funding. Kevin, you look like you have some thoughts on that.
I was actually going to address some of the issue when you raised the concern around pandemic in the Indigenous population. Obviously, our research is still lacking and slightly behind the times. What I'm reflecting on is what we see in the US with a huge disparity in terms of accessibility to care and the death rate among ethnic people, around people from different cultural background. I think I think we need to think about policy to answer your question, and also to look at our population. How can we develop fair policies and transparent policies that are equitable, accessible by all Canadians, Indigenous population, and other cultural population as well. So I think we need to think about ways to address the racialized population, especially given the recent social movements that we've been seeing, addressing some of those major determinants that put people in a very disadvantaged position based on the ethnicity, based on language barriers and their belief system.
Well, that's a really great question. Before we give others a chance to respond to that, there's a question here from Heather that sort of touches on what the challenges for families in trying to navigate that and try to figure out what is the best place, because it's not a one size fits all in terms of what places are available, whether it be seniors residences or long-term care. And I think those of us who are connected to this work think that that's common knowledge, the distinctions between different types of organizations. But what advice do you give to families who are on this suddenly a huge learning curve? John talked about frailty, and we know how people can slip into frailty often very quickly, and suddenly a family who's never had to think about the fact that they can no longer support their loved one as well as they could living at home, and they're trying to sort of figure out their way through, navigate through this. What advice would you give to someone like Heather, who is one of many people who has faced that challenge and stress of trying to figure out what's the best way to care for their loved one? Any takers on that? Catherine, you've got the community perspective there. What advice do you give you and ask you about, where do I get help?
Yeah, and it's interesting because we often turn and think about home care as a solution, and by all means they provide significant supports, but we also forget to think about community support services. So these are those support services like Meals on Wheels that are often sort of not spoken of, and there's really not a lot of data on the type of care that's provided. So we can't often respond to sort of how much those services are being used, and they're often off the radar of our conversation. So I would say, thinking about the broader community services, support services out there, we also know that not everyone in Ontario has access, but primary healthcare teams and Laura alluded to sort of the larger team and, you know, thinking about, again, going back to these geographies. And I guess I would highlight that as well. You know, we've seen a lot of data highlighting vulnerable regions of the socio-demographic variables. But I think we haven't added age into the equation. So we look at population, say, in the north west of Toronto, but again, what's the age component of those as well? And so, you know, how do we support these more vulnerable sort of populations and, you know, link these community services more specifically? But from a family perspective, you know, thinking about large, broader community support services would be something I would suggest as well.
That's great, Catherine. I'm cognizant of Laura's marking us on how quickly we bring youth into the conversation, so I'm a bit scared to bring up the next question, but I think it's a good one. Sandy asks the question about what we're doing on intergenerational work, and particularly the bringing young people together with seniors in meaningful ways. And of course, this has been particularly challenging right now because of the restrictions on people who are living in facilities where there are almost no visitors. But we all know how transformative this can be, how young people can become advocates for the elderly, and we've certainly seen international models that I would say do better than Canada on this. So any of you working on intergenerational issues that could share your wisdom on that? Laura? And then John?
I actually can talk about an intergenerational issue that we're doing at CanAge with Queen's University. So it's as close to home as possible. We reached out and had a conversation early on within the advancement department and said, how are we supporting more community-based alumni who may be experiencing social vulnerability and isolation on an ongoing basis, but also in particular during the time of COVID-19? And under the leadership of VP Bertrand and the great team at Queen's, I can share with you statistics as of today. Right now at Queen's, we have 76 volunteer callers, 64 students and 12 are alumni. And we have at least about 50 odd senior alumni receiving a minimum of weekly calls, sometimes more than that. And we know that we have alumni pending. This type of program that's at Queen's, where you have a trusted group, is a wonderful way to create intergenerational supports. And we just had a feedback session from the students that were doing it. And they said that they're finding it incredibly enriching for themselves. And really they're providing not just support to older people, but this is an exchange. Wherever we see intergenerational programs, we see benefits across generations, whether it be co-locating adult day respite services with daycare services, whether we talk about having co-housing supports with home share type programs, which allow older people to gain some money and have somebody in their house to provide some additional light supports. We know that intergenerational is a huge part of our solutions, and we're really excited to support that.
That's terrific. John, did you want to add to that?
Yeah, Laura stole most of my thunder, but I did want to mention some really neat work that I've been involved with. Well, a colleague has been the lead, and I've just been peripherally involved. John Lewis at Waterloo. He has been providing leadership to a program called Bridges in Waterloo, which brings together the young and old elderly, but particularly focusing on multicultural. So new Canadians and Indigenous groups. So it's targeted to not only break down generational barriers, but cultural barriers. And they have some really neat work from a pilot that we're trying to get some funding to run in several other communities across Ontario.
Wow, that sounds really interesting. So thanks for sharing that idea. You know what, our time is slipping away so quickly, and there are literally dozens more questions. So what I want to reassure the audience of is that everybody who's put a question in, I know that our amazing teams are going to do some background work and try to get answers to you on as many of these as we can. So we'll find ways to follow up, and certainly we'll take note of all the questions. We're getting so close to the end. I want to make sure everybody has sort of a last minute chance to do a pitch, a last message. And, you know, John needs money for a bunch of stuff, it sounds like. So He's already put that forward, but apart from resourcing this really important work, what other messages would you like to leave? And I'm thinking particularly for policymakers in the context of what we've learned over this extremely difficult time of the COVID pandemic and the impacts on the elderly. What's your final message that you're going to be really pressed with in the weeks and months to come? Let's go to Catherine on that one.
Jane, I think everyone wants an immediate solution and policies for immediate implementation, but I think we have to play the long game here and really looking at policies of how we shift our approach to thinking about aging in general. So, I would have policies much more upstream and, how can we bring community services to older adults where they're living? And, I could get much more specific, but again, shifting much more to communities and supporting seniors where they're living and our own perspective on aging as a society.
Thank you, Catherine. And it's just terrific to hear about the amazing work that you're doing. And thanks for helping to keep everybody well connected on that. Kevin, what are you thinking? You're right there in the heart of this work. What's your key message you want to leave?
Well, I still want to go back to the message around education, not just because I'm an educator, but when you think about the quality of care, and there's so much research done in this area in terms of highlighting the more qualified people providing care at the bedside, the less risk that patients are going to experience, the less medical error is going to occur on a day-to-day basis. So that's a very strong evidence out there. And unfortunately, policymakers are not picking up that message yet. Well, maybe they know, they just don't do anything about it. So I think it's time for us to really act on that. I saw some of the questions earlier in the chat box about personal support workers. They're a huge workforce in long-term care environments. How do we improve the knowledge? How can we improve the quality of care they're providing direct to the elderly population here? So I think the key message is education.
Education. Well, as most of us are educators in one way or another, so you absolutely can't go wrong with that. Laura, what's your key policy message you want to leave in our minds for the minds of policymakers?
That it's absolutely doable to fix. There are problems in this world that really are enormously challenging. And actually, seniors care in Canada is not one of them. We have the recipes for how to go about it. We have excellent research and researcher, many of them are at this team. We do need more research, we do need more education, that's not a question. But in order to create it as a policy focus, we need to provide answers. And as I say, at CanAge, we are releasing a national seniors policy platform with many of the answers that we believe have already been found in the system. So it's about time and attention and care. And if we can bring time and attention and care by having conversations like this, policy can follow.
Well, that sounds great. So we've got the perspective of importance of education, the importance of realizing it's going to take time, but we have the answers, which is really great. John, what would be your final pitch to policymakers as to what have we learned and what should we prioritize?
Well, I guess a key message I'd suggest is aging of the population is not the problem, it's the solution. The majority of older adults are assets and resources. They donate more in terms of charity, in terms of time, in supporting our healthcare system and other things. They're the primary caregivers of many frail older and frail young people. So the reality is we should be celebrating aging, but see it as a resource. So this is where the age-friendly community movement really has a tremendous opportunity, because if we build a community that meets the needs of frailer older adults, it meets the needs of the whole population. If you plan the community for 20 to 40-year-olds, it doesn't meet the needs of much of the community. So it's really, we need to change our way of approaching the issue. Aging isn't the problem, it could be the solution.
Wow, John, I cannot imagine a better way to wrap up our comments than focusing on seeing seniors as the assets here, and making sure that we make use of that incredible resource. I know if my mother is listening to this now or in the future, she'll love that answer, because she tells me all the time that you got to go to seniors. They already know what needs to happen. So what a great way to end. Well, thank you to all of the panelists. You have really been spectacular. I have thoroughly enjoyed the conversation. Thanks to the audience, all those of you who have sent in questions. We have, I think, moved along the conversation. There's a lot more conversation to happen yet on this topic, but I'm going to hand things over to Karen Bertrand and ask her to provide some closing remarks. Thanks for joining us. Over to you, Karen.
Thanks, Jane. And I was thinking about some closing remarks, and I think, Jane, I agree with you in full. Let John's comments be the final ones. It could not have been said any better by any of us, John, so thank you for that perspective. Jane, Laura, Kevin, Catherine, and John, thank you all so much for this incredible conversation. It is absolutely clear to me from both the number of people that registered for this event, as well as the sheer volume of questions that are coming in through the Q&A function in the chat, that this is a topic that is near and dear and obviously important to so many. It heartens me that there are so many members of the Queen's community really quite committed to making improvements and doing better by our elderly Canadian neighbors. So thank you very much for all that all of you are doing. And thank you so much for being incredible representatives of what we, members of the Queen's community, can do to advance and make a significant impact on the issues that matter to all of us. Just a reminder to all of the guests, we are recording this event, so you will be able to access it on our website at queensu.ca/alumni. It will be available in the coming days, so do feel free. I see a number of comments in the chat about wanting to spread this recording to other people so they can benefit from the information, so you will definitely have the opportunity to do that. We will be hosting additional Conversations Confronting COVID-19 lectures in the fall. Those topics have not yet been determined, though I think Jane has proposed a couple of topics in the past hour. So we will definitely look into what some of those topics may be. But for all of the participants today, you will also be directed immediately following this event to a survey. So please do provide your comments through that survey, which will help us shape our programming going forward. On behalf of Jane and everyone on the panel, thank you so much to everybody who has joined us, and we look forward to hopefully joining you at another event in the fall.